So hello and thank you for coming along to this session. I'm Maddie Desforges. I'm Chief Exec at NAVCA, which is National Association for Voluntary and Community Action. And you see we've got a range of panellists around, which I'll introduce you to in a minute. So this is a session on making sense of place to support communities' mental and physical health needs, which feels really directly relevant back to the overall theme of the conference around collaboration and resilience and system change. So this session will focus on place-based working and really how partnerships are developing locally to provide better and more joined-up care, more holistic care for communities. And thinking about the voluntary and community sector particularly as a key partner within those systems, as well as how health and care bodies interact with and relate to the community. And that feels really important at the moment with the ICS transformation, and as we've got national guidance which has put those place-based partnerships as the building blocks of integrated care, really for the first time incorporating the voluntary community sector with the potential to really lead and drive that work on strategic planning, on service change and getting into some of those really knotty problems around population health and well-being and tackling inequalities. But to make that work, we've got to bring together the full range of system partners. So the NHS, obviously, local government and primary care, fairly obviously, social care providers, and also the voluntary sector. So the point of this session now is to think about the role of different partners at place and how they can work together for the benefit of local people, and think a bit about the strengths and the assets of each. So I'll start with a short presentation from Julian Hartley on the work that he's doing in Leeds teaching hospitals as an anchor institution to reduce inequalities and improve health and well-being. I'll talk a little bit about the role of the VCS, and then we'll go into a conversation and panel of speakers who are both from within and outside the NHS in different bits of the NHS, thinking about how place-based collaborative working can really improve lives and drive change. And what are the collective issues around inequality, the cost of living crisis, which are going to make that more and more important over the coming years. I want to really, if we can, get into thinking about the enablers and the barriers of integrated care and what support is needed both nationally and locally to start to get into some of the solutions or the choices to work through those challenges. So I want it very much to be an interactive session. We'll take questions from the audience. I'll be given instructions on how to use an iPad to collate questions. We've got a roving mic to go around if you want to come back with supplementaries or ask something else. So there's various ways in. I've got instructions on here for how you submit questions. Does anyone need me to read that out, or are you all on Glisser now, having been in previous workshops? Yeah, is you on Glisser? Yeah, okay, I won't go through those then. So let me introduce Julian to talk about Leeds and the NHS Teaching Hospitals Trust as an anchor institution.
Thank you very much. Well, good afternoon, everyone. It's great to see you all. And I'm sure as I go through this, I'm sure many of you will recognise a number of the things I'm going to talk about, but I just wanted to give you a perspective from Leeds Teaching Hospitals and indeed the Leeds system about how we're approaching these challenges. So maybe if we could pop the slides up, that'd be great. I've just got one or two slides to share with you. Well, I'll start, shall I? Yeah. So, from the perspective of us in Leeds Teaching Hospitals working as an anchor institution, we're really focused on trying to provide training, education, employment opportunities to create those resilient communities. And it's interesting, isn't it, that resilience is the theme of our Providers Conference. Excellent. So if we move on to the next one, the importance for us of the wider determinants of health. And I think this is something I think every hospital trust is increasingly aware of and conscious of, in the sense that we all work within this context in all of our organisations. So healthcare actually only makes up a small proportion of our overall health. All of those wider determinants are crucial. And as an anchor institution, As a major employer, we employ 22,000 staff across our organisation, a major purchaser with a 1.4 billion budget, owner of land, estate, 7 hospitals across a whole range of city sites. We have got a big opportunity to address those wider determinants beyond what we do in terms of our core mission. And that includes health inequalities, removing barriers to employment, influencing our spend and reducing our environmental emissions and pursuit of our net zero carbon plans. And in Leeds, on the next slide, you'll see our ambition. This is an infographic of the health and wellbeing strategy. Our ambition is for Leeds to be a healthy and caring city for all ages, where people who are the poorest improve their health the fastest. Now that has been something we've talked about for a number of years, and it really resonates, the idea of improving the health of the poorest the fastest. And all of us talk about this, whether we're working in the emergency department, in dermatology, or as, in social work or community services. This is a collective mission across the city because it really does matter in terms of all of our efforts to achieve that. And all of the, if you like, the golden thread from the health and wellbeing strategy filters into all of our organisational plans and business plans. And if we move on, you'll see across the outer rainbow are the 5 values of what we call the Leeds Way, which is our values and behaviours within the trust. But it maps very, very clearly in terms of the 3 areas we think we can make a real difference in our role as a trust to the wider system. So first of all, as a partner within local health systems, working with partners in West Yorkshire and Leeds to improve health and access to health and social care. Of course, as a provider of clinical services, ensuring inequalities are considered within those. We did some work with colleagues across the West Yorkshire Association of Acute Trusts, particularly with Owen Williams while he was in Calderdale and Huddersfield, on how health inequalities manifest themselves in hospital waiting lists. And it has been absolutely fascinating to see some of those inbuilt inequalities in terms of understanding those waiting lists by index of multiple deprivation, by ethnicity and so on, and then challenging ourselves about what we need to do to address those. And as an anchor institution, maximising social value through employment, procurement, environmental impact, facilities, and our major capital programme. Many of us, I'm sure, have got aspirations for better capital facilities for our patients and communities. We are no different. We have a major plan for redeveloping the Leeds Children's Hospital and Leeds General Infirmary. I think we're all waiting with bated breath for tomorrow to see where our capital plans and aspirations land in relation to the autumn statement. But certainly, designing those facilities with this agenda in mind is crucial. So if we think about the Anchors Network, on the next slide, the Leeds Anchors Network brings together the city's largest, mainly public sector employers to focus on areas where we can make a difference and scale that impact up. And members include obviously the City Council, University, Yorkshire Water, Leeds Building College and ourselves. And there's various subgroups looking at procurement, employment, and we benchmark our progress against each of those ambitions. Each year we set a record of metrics and then measure progress against those dimensions. And then on employment training and education, which I think is fundamental for all of us. On the next slide, we have just some numbers there which give you a sense of the work that the Leeds Health and Care Academy is doing. Now, the Leeds Health and Care Academy was an initiative some years ago to deliberately bring together the whole of the NHS across the city, together with the university, city council, to create one entity that's focused on delivering for the 57,000 people that work in health and care across Leeds, to learn together, work together, and we've done some specific work on recruitment in some of our most disadvantaged communities, our priority districts. And if you came to St James's Hospital, you'd see right on the doorstep Hare Hills and Lincoln Green, some of the most deprived parts of the city, where we've deliberately used the academy, has gone out to do jobs fairs and recruitment in those communities, and it's been very successful, and we've been able to recruit a number of valued colleagues from those communities as part of our team, and the academy's also been very successful in apprenticeships as well, which of course is hugely important. So just to kind of personalise this, the next slide shows you John. Now John is one of our valued colleagues. John was working as a youth counsellor in a church in Kenya, but when things became dangerous following political violence in the country's Rift Valley area 3 years ago, he now lives with his wife Bernadette and 4 children in Hare Hills after being given leave to remain in the UK. And after a 6-week course, both John and his wife were offered roles as facilities technicians, work which includes support on the wards and porter duties. And John's story is one of many of those colleagues from that part of the city. And actually, I think what it's doing is it's really bringing to life for everyone that works in the Trust the importance and value of our engagement in this agenda and with our communities that are right on our doorstep. So if I just perhaps say a little about the capital challenge. So on the next slide, Building the Leeds Way, as I mentioned, it's a programme across the Trust, and it's a major opportunity to deliver social value. The team are working closely with suppliers in both the new pathology laboratory that we're building at St James and the LGI development, the new Children's Hospital and new LGI, to design and deliver social value initiatives, including employment and apprenticeship opportunities and engagement with schools. We've got a team of fantastic, daring designers from schools and indeed patients of the Children's Hospital to come up with ideas and innovations for the content and design of the new hospitals. And we're also trying to measure the impact through the socio-economic impact of the initiatives measured through the themes, outcomes and measures framework, quantifying the benefit of those initiatives in monetary terms. And recently, the team have worked with the council's rangers to plant over 600 trees around the city. One of our suppliers, Arup, has hosted 20 Year 10 girls from Seacroft Academy, one of our priority neighbourhoods, to take part in a series of activities and learn about engineering careers. And the construction contract will be a significant opportunity to further these initiatives. And then just to highlight Shape Up for Surgery, which is a campaign on improving patients' health before surgery. And given the challenges around the elective backlog we're all facing, we cannot waste any of our surgical activity, and therefore making sure patients are absolutely ready and fit to come in. It involves educational videos on healthy eating, resources, guidance on quitting smoking and reducing alcohol consumption, and how to access options for increasing physical activity. So it's not just that sort of acute intervention in terms of the surgery, it's trying to make sure it's connected to healthy lifestyle and maximising the benefit of that surgical intervention. And that goes alongside the Stop Smoking service, recently launched with inpatients on our respiratory wards as well as in the community to support people to stop smoking. And patients are given free nicotine replacement therapies to access specialist support while in the hospital before being referred to community-based services once they're discharged. So some examples, I guess, to get us going on this conversation of what we're doing. I have no doubt all of you are engaged in similarly important and inspiring work, but now more than ever, my sense is we need to be collectively working on this. So very much looking forward to the conversation. Thank you.
Thank you, John. It's a great way into the conversation, and it goes right to the heart of that point about how do we make sense of place to improve health. I just want to build on that a little bit. So you talked very much about the role of anchor institutions, so the NHS institutions, the universities, the council, for example. We've got that range of people on the panel representing different sorts of institutions and organisations. And something about the role of the voluntary community sector in all of that, around really enabling people to take action on what matters to them, on shaping places, on taking control of their lives and how that works. And increasingly we're seeing the safety nets being provided by communities in the absence of the holes in the safety net elsewhere. And that feels really important, that sense of resilient communities. And we talk in NAVCA about resilient communities being places that can withstand shock, whatever that shock is. Thriving communities being a place where people can live the best lives they can, which enables human flourishing. And I think the point about those anchor institutions investing in business through contracts, investing in people through jobs, ultimately helps communities move through that transition from resilience to thriving to individuals flourishing, which feels so important. And there's something about the value of the voluntary community sector and all of that around the relationships and the intelligence that community organisations have, around being involved in system change and problem solving, as well as service design and delivery, which is often where we go to in terms of thinking about involving the community. So I think there's something very much about having similar goals between different sectors around equality and health and the wider determinants of health, but often very different approaches to achieving that and different culture. And it seems to me that if we're going to make sense of place to really drive health and drive resilient and thriving communities, we need to think a bit about those cultural changes, cultural differences, as well as the things that bind us and the things that we're working on collectively, and how we can make best use of the assets across different bits of the system in working together as a single system to get the best outcomes for people where we live. And perhaps that gives us a way into the conversation. But first of all, let me, I'll go from left to right if that's okay. So come to Julian last, you've already heard him talking. If you want to say, in true Still Black fashion, as we're in Liverpool, who you are and where you're from, and perhaps a little bit about your organisation and your interest in place. So let me start with David.
Thank you. So I'm David Fothergill. I'm a councillor in Somerset. And I also chair of the Local Government Association Community Wellbeing Board. The Local Government Association represents all apart from 4 who resist to join us, but apart from that, we won't mention those, across the country, and we represent as a lobbying body to government as well as doing some quite useful research work as well. And within that we have a number of boards. One of those boards is Community Wellbeing Board, which represents every aspect of social care, public health, everything from dentistry right the way through to apparently Armed Forces Covenant as well. So that's the board that I look after.
I'm intrigued which 4 aren't in the LGA now. I'll nobble you afterwards on that.
Well, nobody here from Leicestershire, is there? Oh.
Let me use Dr. Laura Nielsen. Say a little bit about where you're from.
Yeah, so I'm Laura. I do paediatrics clinically, but most of the week I lead a primary care organisation. So I set up a GP practice when I was a medical student in the estate that I lived in, which was very poor. And so now we have 12 practices, all in very deprived areas of bits of Greater Manchester. And I'm a complete and utter health inequalities geek, activist, nightmare. And over the last 15 years, I've piloted lots of different ways of reducing health inequalities in the places where we work, working with lots of different institutions and working with anyone who will give it a go, really. So that's what I do.
So do you still work in the place where you grew up then?
No, so I grew up in...
I misunderstood.
Yeah, no, I grew up in posh St Albans. I went to a girls' school where I wore like a deck chair blazer, played lacrosse and learnt embroidery. I then hit the real world and I did a gap year in Manchester as a youth worker, and I never went home. And so basically for the last long bit of time I've been in Greater Manchester, a lot of that time in Oldham in an estate called Fitton Hill, and I'm passionate about seeing change from place out.
Thank you. And Ginger Candola.
Hi everybody, I'm Ginger Candola. I'm the Chief Executive of 2 London trusts, Camden and Islington Foundation Trust and Barnet Enfield and Haringey Mental Health and Community Trust. Probably running services in some of the most deprived London boroughs. One of our boroughs is 92 languages, highest levels of deprivation. A tube line runs right through one of those boroughs, and if you start at the top end where we serve, life expectancy is 25 years less than the other end of that tube line. So real deprivation, disenfranchised communities, and I'm also the ICS mental health lead. So really interested in actually driving improvements in mental health so that actually individuals can have a better and fulfilled life. So that's my interest in this.
Thank you. Julian, I think you've introduced yourself already, haven't you?
You've heard from me.
So there's no questions coming up on Glisser, so have a think about what you want to think about in terms of place-based working. But let me open with the panel. Can you tell me a little bit perhaps about what you think are the, what does really successful place-based working look like? Where are we trying to get to? What does it look like, and will we know when we get there? And that perhaps gives us a way into thinking about the opportunities, the enablers, and also the barriers of that sort of approach. Who wants to
I'll have a, yeah, I think there's something about in disenfranchised communities. So if I think about some of the services that we run and mental health services where individuals may be taken into via a section where you've got 2 or 3 police cars and ambulance, and the lack of trust in any institute. So the NHS says they're going to become an anchor institute working in the local community. There isn't the trust. So I think there is something about how do you build that trust? And I think that's through the community voices and our community groups. So that relationship at a local level is something that's really made a difference. So I've got a colleague here who's looking across at, who's worked in Haringey, and I think one of the things that I found was actually community leaders who actually tell you what the community needs, not what I, as a leader of the NHS, thinks, but actually what our community needs. And then being brave enough to marry that up with, well, actually, that's not what I signed off in my corporate objectives. That's not what we said, but actually this is what our community needs. So bravery to be able to build that trust. Because once you've got that trust, then you can work a place. And I think the link between poverty and mental health, I don't need to repeat that, it's well known. So actually, how do we help individuals to have fulfilling lives where they have somewhere to live, a job and meaningful relationships? So I think that comes with some of that.
It's really interesting because I was talking just now about culture and the cultural changes between the voluntary community sector and some of the NHS systems and structures. One of the things that I find most is that we can ask for quantitative proof that such a thing exists. But I think there's a massive amount of intelligence and information in the, there's a massive amount of intelligence and information in the voluntary community sector, but it's quite difficult to tap into from a big NHS perspective where it's about health economics, and thinking about how we gather that intelligence and information about communities and use it really effectively seems to be a really important part of it. Let me go to Laura.
I think it's really difficult. I think at one level, sometimes we talk about place, which is lots of like chief executives knowing each other, and that is definitely a start. It's useful when your key individuals in a local economy actually get on and like each other. I will say that. If they fall out, it's a blinking nightmare if you're underneath them. So there's that bit. And then there's a bit about the community getting on well together, and often that is the voluntary sector, and often that is the faith communities, and often that's just how neighbours work together. And then there seems to be a gap between the two. And we often talk about examples at the bottom and examples at the top, where we've got key policy documents that say these anchor institutes are going to work together and share key objectives, and you're going to go out for breakfast with whoever your equivalent is, and it's all going to be hunky-dory. And at the bottom, we've got the voluntary community and the kind of grassroots people who often do know each other quite well and also need to get on and not fall out and be parochial. And then the bit in the middle, I think, is the bit we struggle to do. How do you do top down, bottom up, and how do you have a coherency across that in the middle? And that is about trust, it is about bravery, it's about relationships, it's about talking to people, it's about curiosity. One of the things I've learned is that no estate is the same. So the statistics can look similar. I can think this is a certain brand of poverty, and then I arrive there and think it's just quite different. And so I think having that curiosity to find out actually what's going on. And then we're not going to be able to solve all our place problems. So there is something about picking things to have a go at that I think all institutions need to work that out. I love your thing about looking at waiting lists and deprivation. One of my first unpublishable pieces of research, there's many of them that never got published for various reasons, but this was unpublishable because it was politically awful. I counted in outpatients when I was a medical student the demographics of people whose kind of the socioeconomic scale of people, how poor they were and what level of doctor they saw. And basically the poor people saw the junior doctors and the rich people saw the consultants. And the medicine is the other way round. And so even being aware of that, the Trust did not want that published, obviously. And you know, things like that, we need to be putting our best people where our most complicated patients are. We need to be putting our best social workers where our most complicated families are. We need the NHS to be the best where it's needed most. And I think if we do that across all our institutions, that's when we start seeing places thrive. But that gap between the layers is the bit I find really fascinating.
That's a great challenge, isn't it? To put the best people where the most intractable problems are. I like that. David?
I think for me the exciting thing is that we're actually talking about place.
True.
Because I suspect a few years ago we weren't, and it's risen to the top of the agenda, and there is a recognition that plays a really important part in people's health. And you know, we talk about the 80% of health of determinants that are outside of the hospital, which determine people's health. So for me, the fact that we are talking about it, but I think there's some big challenges. So from local government's perspective, you know, we have 18,000 councillors out there who knock on doors virtually every week or every month and talk to people. They are a resource that we need to bring in. We need to spread the place definition as wide as possible to ensure that those people can contribute, because they are talking to communities and individuals. We need to make sure that we're including the voluntary and community sectors. We need to make sure that we're including the GPs, the primary care, and the faith groups. There is the real importance that we don't restrict how we define place, and that we involve as many people as possible. And I think some of the work that's gone on in health and wellbeing boards, I think is really exciting. And then the introduction of the ICSs, the ICBs, the ICPs, I think is a good step forward. But there are some real challenges, and I'm sure we'll come to the challenges as well. But for me, place it's exciting. It's what I do. That's why I'm a councillor. That's why I stood for election. And because it's about representing people and where they live, and all the levers that you can pull to try to improve their lives. It is an exciting place to be. I'm really pleased we've got this on the agenda.
It's fantastic, isn't it? Because likewise, I'm committed to place, but we're all in places.
Yeah.
So why do we overlook that sometimes and go straight to national or system or anything else? We all live in a place and exist in a place.
Yeah.
Julie, let me come to you last. What do you think what does really good place-based working look like?
Yeah, well, I was struck by what you just said, Laura, about it's okay for chief execs to come together and get on, and fine, absolutely, but that's not enough. And I think you're absolutely right. One thing, listening to you describe some of those estates that resonated, was every couple of years we do something called a big lead chat, which is where we all put T-shirts on, clipboards, and get out into, you know, Leeds Market, Streets of Morley, and so on. And once I've persuaded people I'm not actually after their money, we have a conversation about health, and we all do that. And what's fascinating is getting a street level view of where people are at with their relationship with, whether it's the NHS, other services, and it's amazing, and it brings it home what we were just talking about. It's about the whole thing. It's about how things join up or don't join up and connect. So we've worked really hard to try, as leaders, to understand our responsibility for bringing together not just ourselves in meetings and governance and so on, but actually our teams. So our teams, we run a programme, a Hearts and Minds programme, which is all about all staff in all our organisations understanding that they're part of something bigger. The importance of the academy, the role the academy plays in doing that, and just making common cause really as organisations, having management development opportunities in each other's organisations and so on. And I think crucially the relationship with local elected members and MPs and politicians, because they are part of the place as well. So our experience of the pandemic was one where every week we'd join a goal command led by Tom, who's the chief exec of the council, all of us involved in that. But I think it bound us together in the sense that so much is dependent on each other, and that those interdependencies really came to the fore in how do we get through particular challenges. And I think I'm sure that's the case for lots of colleagues in the room in terms of your own experience. It has, I think, sharpened our sense of the ties that bind us together. So that there's an emotional as well as an intellectual component to this, and there's I think never more important to really understand the experience of our patients, citizens, service users to help inform our partnership working.
So there's a question which picks up on a couple of things that we've said as a panel. About the importance of place and the ICS agenda really driving us to work at place level. But are we battling against a political agenda that doesn't really support levelling up, doesn't really support place? It's still very centralised in terms of Whitehall. And how do those tensions play out at place level between levelling up at one level, sorry, too many levels, levelling up wanting to address some of the inequalities and think about how we have greater autonomy at place and we have decisions made at the most appropriate place, combined with a very centralised system. And is levelling up really going to happen? How does that play into the whole ICS system transformation and place-based agenda?
Happy to go on that one. So I think one of the important things about the ICSs when it was set up is that there is an ambiguity built in. There is a sort of looseness of definition, and that enables the 42 different areas to deliver something very different, but which is really relevant to them and to their place. And I think we would absolutely argue that has to be protected, and that the more top-down metrics and measurements coming down, it will begin to stifle. We need to keep those 42 places really working very tightly, but working on what their priorities are. Does it compete with the levelling up agenda? No, because actually we know what our priorities are in our area, and my priorities in Somerset are very different from Manchester, I would imagine. We have some similarities, but there are a lot of differences. So we have to recognise that by having ambiguity in the process, by having that lack of definition of ICSs and how they should and have to run, it actually works for us, and we can counter that political message about levelling up, so that we can achieve levelling up in our own area with our own priorities.
I think just building on that, I think there's something about freedom in a framework. So if you think so, in the ICS I work in, there's 5 boroughs, quite vast boroughs, but actually you can't do the same thing in each of them. You can't do the same thing in each of the neighbourhoods, because they're very different agendas. And once you get your head around that, actually, there is something about, if you look at the ICS's issues around addressing inequalities, trying to eliminate some of the variation in service, if you give the freedom at place to drive some of that, then you are actually addressing the levelling up agenda without sort of dictating downwards, but you're giving that freedom. So I think we always need something. There will always be challenges, and I think that framework to allow freedom in that probably helps with some of that tension.
Fantastic. I've got another question, and given this is an NHS provider conference, I feel slightly trepidatious about asking it. And it's something I hear fairly regularly, is that people feel, leaders feel, place leaders feel that they're being pulled into NHS structures. And they're being pulled into what can feel like quite big and unwieldy NHS structures. There's a number of different committees and subcommittees and boards and everything else that are being put in place around ICS transformation. And there's something about how can we shift the dynamic so it feels like we're pulling place leaders into addressing issues across the piece, rather than place leaders being pulled into NHS bureaucracy. My words, not the questioner's words. And that feels like we've got to get that right, so we're going to achieve system change which benefits people at place level.
I don't know. I can say this because I'm not one of you. I have seen within the NHS since I've been around, which is not, it's 15 years, numerous tags and flags and reorganisations, and I think in some ways delivering for places in spite of and despite of what happens around you. And we can definitely say it in our current politics, who quite frankly knows what's going to happen. So I think as a place, as a leader within a place, whether that's like within a primary care or voluntary sector or a chief exec, your main responsibility is to the public service of that place. And that's the primary thing. And then all your structure and all your logos and all your strategies come around that. So if you have a board, what is it for? And I think there needs to be a difference. I've sat in through and endured many where, you know, is it an assurance board? In which case, let's talk about assurance, but let's do it really well and like accurately with the right data and the right stuff. Is it a dreaming board where we're dreaming the future? In which case, have the dreamers in the room, don't have the blinking bean counters. You know, is it a community engagement activity, in which case get it done well and get the right voices? Quite often we have meetings because we think we need a meeting, and we might have a, you know, a scheme of delegation or a, you know, thing describing the meeting, but actually we don't really know what it is. And so then in that meeting you're talking about trees and acute beds and training programs and building a, you know, a green car battery factory somewhere, and it all gets very muddled and you've got completely the wrong people in the room. So I think whatever your structure, it needs to fit the purpose and be really clear what it is. The NHS is brilliant at assurance, it loves assurance, it's brilliant at spreadsheet. Not everyone has to sit through talking through that spreadsheet. And so get the right people in the right room. But whoever you are and whatever the politics is, I personally feel we are here to deliver the best we can for those people and for that place. And that is regardless of our job title, who we're paid for, or quite what infrastructure we happen to have had imposed on us, which will probably change again in the next 2 years. So, you know.
Yeah, there's a lot in that, I think, that Laura said I agree with. I think that the other thing I'd add would be the importance of the relationships locally between the leaders of the organisations and all of the staff that work in them, because we are big employers. In any town or city in this country, local authority, university, the NHS will account for the majority of the public sector workforce, and therefore we've got a huge opportunity to kind of galvanise the collective efforts and engagement of our teams. I do think there is an inbuilt tension between the way the NHS is led and managed, because it is very different to local authorities, and there's some inbuilt tensions in the conversations we have about patients, you know, 300 patients with no reason to reside in Leeds teaching hospitals, and how are we working with Kath Roth and her team in social care these are constant, but we have to sort of make allowances for how each other operates, for the very important local democratic accountability that the local authority has. We have a different one through our board, and now with the ICS and NHSEI and our regulators. They're different worlds in a sense of kind of experience and accountability, but we come together with a shared purpose to serve our citizens, patients, communities, and that's what really counts. And I think, Laura, I agree with how you're emphasising that. So I think anything that we can do to help break down some of those inbuilt sort of potential silos, really, the better.
So I've got a supplementary question which builds on that, really, particularly where you were at the TransUnion, about how we align our efforts across the system when we're working at multiple levels. So we've got providers, we've got place-based partnerships, we've got ICSs, and they're all kind of working in that place space. So how do they work together, align, have common purpose, or doesn't it matter?
I think there's a degree of bumping in that will happen. I think, let's face it.
That's very polite.
Yeah. I think if you go back to the height of COVID, and what you saw at place was different people coming to the fore and looking with the same one objective, which was to keep people safe and make sure that those individuals who were vulnerable, who weren't able to go out, were being looked after. That community space and that place thinking got you to where you needed to be. And then obviously what we do and what we're really good at in the NHS is put layers of bureaucracy and accountability and assurance on top of that. But actually, if you go back to that, there was a degree of bumping in. And I have to be honest, I kind of thinking, well, why is the large football club coming along to this meeting as well when this is all about healthcare? Actually, that was the place where people were going and needing the help. So I think it's okay, and I think we will work it out. But if you prescribe it right from the beginning, it won't work. And I think you've got to allow a local place to work through that and give them the time and space to do that. And I think they will get there, but there will be a degree of bumping in.
I think, well, first of all, I'd say to the last question, I think we all have to play our part and we all have to treat one another with respect, and then we will all get on, I'm sure. But in terms of this question, I'm a great believer in health and wellbeing boards. I think that a lot of good work goes on at health and wellbeing boards, and we ignore them at our peril, and we lose them at our peril in the ICS new world. Because that's where a lot of the voluntary sector and a lot of the actual doers come together, and we do some really good work. So that's really important. For me, I think it's quite simple. It's about relationships, people building relationships, recognising that the NHS tends to look up, controversial, whereas local authorities tend to look out. You would argue with that, I'm sure. But the real problem for us comes when, if it's a simple system, it works because you have clearly identifiable leaders. And Somerset is one of those, we have one authority, we have one trust, we have one NHS, etc. But when you go across local authority boundaries and you go across different boundaries in different ways, then you get not only different political parties coming in, but different leaders coming in with different priorities and different objectives and things. And that's when it gets quite complicated. And I think that we have a number of the 42 ICSs which will need to be reconfigured because they're not working. And they're not working because they're too complex, and those personal relationships are getting in the way.
Yeah. Can I just come back on that? And I think what you said about health and wellbeing boards resonated with me, Dave, because we've introduced this as well as the health and wellbeing board. We have the health and wellbeing board 2 board, which brings together all of the people, the organisations represented on the health and wellbeing board, but in a kind of workshop setting where we have leader of the council chairing it, and I can see Brodie over there as chair of Leeds Community Trust, and he will come, my chair will be there, we'll have some of our non-execs as well as the accountable officers. We come together and we eyeball the really difficult things we're trying to do, but we have that sort of honest exchange of views and try to all look in the same direction, not one up, not one out. You know, we try to see the problem together and work out how are we, as the leaders in the place, going to tackle those. And there have been some difficult moments in those meetings. You know, I can remember putting up pictures of how crowded our EDs were and the experience of patients in those settings, and as a kind of catalyst and a prompt to try and galvanise action around that issue. And I'm sure, and the same is the case for other kind of challenges around primary care, around you know, homelessness, and so all those things. But I think it's vital we create those spaces for leaders to come together, and not just in the formal public settings, but in private, to have those really honest conversations.
Just to add to that, I guess the really important thing is to make sure that the voluntary community sector are also plugged into those, and then bring in the intelligence, which you talked about earlier on, which can be further complicated because you haven't got one chief exec of the voluntary sector at place. You've got a number of different organisations with different specific interests, either because it's about a particular estate or community or particular condition or a certain sort of way of living. And so making sure we make those interactions and connections really effectively is really important, but quite difficult both for communities to engage with those big complex systems when it's busy sorting out the communities and working with people locally, and also for large institutions to connect with an ecosystem which works in such a different way without that top-down hierarchy. And I was Chief Exec of Voluntary Action Sheffield, so the CVS, the infrastructure body, you may be familiar with at the post level. And I was, you know, people said to me, but can you not sort them out, Maddie? Like, well, no, I'm not the Chief Exec of that organisation. They've got their own Chief Exec on board. I'm an umbrella body. And there isn't the same level of hierarchy and authority in the voluntary sector. So engaging that can be tricky as well, needs some thought. I've got an interesting question here about how do we manage to focus on long-term priorities, short-term priorities with long-term ambitions for place-based working. It's that eternal balance. One of the challenges is going to be, because it comes back a bit to the levelling up question, but how do you manage the immediate challenges and issues we're facing at place and balance that with the long-term ambition for place-based working? Is there a risk that we go err towards one or the other?
I think it's really difficult, and it's difficult whatever your size of organisation. And I mean, I could never be a councillor because I could never stand for election. But the kind of political, you know, there's a lot of instability in all our systems, isn't there? There's a political instability within the NHS. People do change jobs probably quicker than they should. You know, we have this kind of, how do you prove yourself to be the genius in 18 months so you can do the next thing? What our communities need is a sense of longer narrative. And we can talk about that nationally, can't we? The NHS needs a longer narrative than whatever political party can give it. So, but our communities need that as well. And so one of the things that's interesting is you can have alignment without agreement, which sounds a bit contradictory, but you can have a kind of directional purpose that is aligned with a kind of scattering behind of people who don't quite agree on every point. And that's still really important. And so one of the things about, you know, anchor institutions or ICBs or anything is that we could create this kind of longer trajectory. And then underneath that, you've got lots of short-term stuff you have to do. You know, I'm sure the hospital trusts are desperate to try and get their A&Es quite so unchaotic. I'm desperate when I'm working on Friday for it not to be as chaotic as last Friday. But that is difficult to do. And so how do you balance that is important. But don't sell out the long term for the short term glory is my thing, because particularly in poorer communities, they remember and they see. And I've been part of my community for a long time, and there is a cynicism about the public sector coming in and promising the world, and then that person gets another job in a better place, in a leafier place with a higher salary, and the next pilot comes along. And so what our communities need is a bit of a longer term vision, which is a lot to do with training, education, employment. I'm going to say living wage, real living wage, you know, those kind of things. And that has to travel across leadership. So you have to create that sense. And then the short term noise underneath is going to come and go, probably as they investigate, you know, make new targets, let's be honest. But the big things that are going to be important to our places, climate change, employability, green spaces, mental health, access to basic healthcare, that is more important than the short-term noise. And that is tricky to do.
And those things don't change, do they either? Those fundamental priority of people having somewhere warm and safe and dry to live, a sense of purpose and employment which enables them to support their family, those things don't change.
And if we're looking at complete social inequalities of health while I'm here, then, you know, we're talking about at the moment getting to grips with our housing stock, our energy, our food is massively important in health. And if you want to solve our waiting list in 2 years' time, we have got to start to put pressure on leadership for climate change, for energy, for food security. Because I have to say, at A&E, if in another 2 winters' time, if people haven't had heating and haven't had food, will be fundamentally more difficult. Our mental health services will be really difficult. Our addiction services will be really difficult. Our social cohesion will be really difficult. And so whatever colour of politics you are, and whatever level you are in this, for our places, those big issues aren't irrelevant. And sometimes in places we can get a bit quogged down in like alleyways. There's a big one round our way, Ginnells, you know, kind of those things are really important. But if we're talking 10 years, our leadership needs to be bigger than what it currently is. And I think bigger at an ICB, which to you guys running ICBs, and I'm saying make it bigger, must feel like, oh my goodness. But I think the long-term prize is more important than short-term noise.
It's more ambitious, perhaps, as much as bigger.
Yeah.
Maybe. Yeah.
Yeah, I think one of the fundamental problems we have here is that as a political system, priorities change too often when we have changes of political parties. And one of my great frustrations is that prevention isn't a bedrock of what every political party does. They talk about it until they get into power. And it doesn't matter whether it's blue or red or yellow or whatever colour. People talk about it until they get into power. But you know, there's some real frustrations that we are taking decisions today which longer term deliver really poor outcomes for people. You know, the most recent one is the shelving of the Khan review. You know, that's going to have implications on people. But unfortunately, our political system is built on 5 years. And I'd hate to tell you this, but the government is going to be focused on the next election, which is going to be in 2 years' time. And everything that's going to happen now is going to be because of that date in 2 years. And that's the system we live in. And it feels wrong, but that's where we are. And we've somehow got to get over that and persuade people to set some longer term priorities that deliver the things that you're talking about.
There's an inherent contradiction, though, isn't there, between a 2-year time frame for
Yeah.
these governments and the long-term ambition and goals that people living in communities have
Yeah.
faced. And that, again, perhaps goes back to that question about levelling up. There's an
Yeah.
inherent contradiction between levelling up as a national agenda and the local agenda, which is about people's lives, where people have long memories.
I was just going to say, building on that, I think there's something about the ICBs focusing on the longer term and staying the course on that for their local populations. I think individual providers over the next couple of years or a couple of months will be held to account for targets and performance for their individual organisations or their bit of the service. I think the ICB and focusing on the future and really driving health outcomes to address those inequalities, that should be the difference. Otherwise, we'll be back round this circle again and again.
So here's a more straightforward question, potentially, which is how do we, as a system, how do we as leaders try to foster that sense of aspiration and ambition for communities? So that goes to the heart of some of this, and we can sometimes feel a bit separate from it or a bit detached from it. How do we get into it, and how do we really shift that sense of aspiration in communities?
Well, I think what the starting point has to be a sense of hope, optimism that's grounded in reality, and building on things that actually succeed and work. So they might be small things, but certainly you build confidence and get further engagement. Some of the examples that we've all shared today, I think, go towards demonstrating that even in the most straitened economic and kind of challenging times, people can come together and do really, really great work and make a difference. No more so than locally. So there are some amazing people that work in not informal roles, but as community organisers, volunteers and so on, that do astonishing work and influence. Now, these are the people we need to engage with and embrace and support. And that's where I think we start to move the dial a bit on how it feels to be a part of a community and your relationship with anchor institutions that become less faceless and more kind of engaged and personal, where there's a sense of, a shared purpose. So I think that's got to be the starting point, hasn't it, for a lot of this?
I think a couple of things. I think first and foremost, know your population.
Yeah.
There's no good saying, well, I did that over there, so I'm going to transfer that over there. So get to know your population. Build some trust, develop some relationships. Know which levers to press, because if you're pressing the wrong levers, that's not going to happen. And then I think there's something about personal leadership. So actually, if you say that you're going to do something, then do something. You can fall into the trap sometimes of thinking, oh, that's a really good idea, let's do that. Going to a meeting, then you ask somebody else to do that and it doesn't get delivered. You lose that trust. People don't believe in you. The community doesn't believe in you. And I think that those are the things you've got to do.
Okay.
Can I just come back on the point? Because I think we had a perfect example during the COVID pandemic about it wasn't the big institutions that were coming together. I know they came together in Gold Command and things, but it's where communities came together. And they came together with a single purpose. And the energy during that period, I mean, it was a dreadful period, but looking back, the way that communities came together, the voluntary sector played its part, and we all the system worked. It's how do you capture that? How do you put it in a bottle and use it for future? And there's a good example there that we just need to replicate.
and something like common purpose. We
Yeah.
have a very clear common
Yeah,
purpose.
absolutely.
And from my point of view, I'd say that the VCS was listened to and its intelligence was valued in a way it isn't normally.
Yeah.
Because normally it's talking the wrong language, or there's a cultural difference between the evidence and information the voluntary sector has got compared to the whole sort of health economics points. Right, one last very quick question. But before that, somebody who wants Laura to run everything. So if Laura could run everything, that would solve an awful lot of this.
Right.
More of a PM.
We'll be on her cabinet. But then picking up your points about levers, and I'm surprised it's taken us until 3 minutes before the end of the session to get to this, is what about shared budgets? How can we maximise the impact of pooled budgets? Is that the lever which unlocks some of this? Or is it a bit of a deflector? Is it not so important? Couple of 2 minutes.
I think
thoughts.
I've seen shared budgets work, and I've seen shared budgets be another way of arguing. So, like, if it works for your organisation and your system, go for it. If it's going to create more power dynamics over who has to give up what, just find a different way around. Sharing resources, whether that's money or staff or ideas, is really important. And sometimes it's easier to share a small bit than a big bit. And I often say to my children, you know, you're allowed to share the chocolate buttons, you know, because it's only chocolate buttons. And actually for organisations that don't trust each other with shared budgets, start with something that's an easy win. Start with something that's a bit project-based. Don't share the whole of the surgical budget because the consultants will go nuts. But, you know, start with something that you can do. And some of it is probably going to be around these nitty local issues. You know, I'm currently doing a piece of work about families living in temporary accommodation, and which is staggeringly high and staggeringly awful. But it's probably solvable locally between a couple of clever budget shares and a couple of like middle management leadership issues, and a blessing from the people on high. So shared budgets can be brilliant, but I've also seen people spend 2 years arguing over it and nothing happened whilst they were unresolving this budget question. So, you know, be pragmatic with what you've got.
And perhaps part of that's also about outcomes. So going back to your point about waiting lists and getting people surgery ready, there's something about actually there's no point having a huge surgical team ready and there's nobody going to come through to be operated on, and maybe sharing something with communities to help people become surgery ready then helps those long-term outcomes.
I think on the shared budgets question, it's as much about mindset as mechanisms. So we have a phrase, the Leeds pound, which we all have a stake in. Where is that best spent in terms of social care, acute services, community, primary care, mental health, voluntary sector? And so that leads us to, you know, for example, we moved around 12 million from the NHS to social care in order to pay the real living wage for care workers, because that was the biggest threat to the Leeds pound, because it costs more to have patients in hospital than it does in home care and other care settings. So I think that's the perspective to come at it, and then hopefully whatever mechanisms you need to deploy that, follow, but not the other way around.
Thank you. You're poised to come in.
No, I was just going to say, I wouldn't disagree with that at all. I think we have to recognise that it's not your money, my money, it's the system's money. It's how we can improve the health of residents in total, and we just need to find the best way of spending it.
I'm not going to try and summarise that conversation. It was hugely rich and covered an awful lot of ground. Just a couple of very brief reflections. Culture. We seem to come back to culture an awful lot, about the different worlds that we inhabit across the system, about language, about mindsets, about that point about the middle, the people in the middle, and how do we get at those, getting the right people in the room to have the conversation, whatever that conversation is. I think going on from that, the importance of relationships, about trust, about give and take, about understanding and respect, about memory and the longevity of memory that is in place, and people casting back to, yes, but 10 years ago, 20 years ago, this happened, and where can we go to get that, the longevity and the connections to place so we can bring people with us. And I think thirdly, my reflection would be around the importance of shared purpose. Because if you had shared purpose alongside culture and relationships, I think you can get through some of the bumpiness, some of the messiness, some of the stickiness of working at place. And we all know our places. We all know that there is stickiness and issues there. But I think if you have that shared purpose, along with, say, the trust and the relationships, the give and take, I think it takes an awful long way towards achieving place. Let me say a big thank you to all of you for your questions. I hope I've given it justice through the iPad. I was struggling a bit because they all went very small. I say a massive thank you to Julian, to Ginger, to Laura and to David for your insights and thoughts. Really good and great to have a panel with such a breadth of experience and different bits of the system. So I hope that's really brought out some of the challenges but also the opportunities of working at Place.